get off the AI, give it 4 to 8 weeks, see what happens. And we've got testimonials on the page, and I've got patients that will confirm this. They feel great. They feel better than they ever have.
Welcome to this channel. I am Dr. Steven Devos, the lifting dermatologist, and this is my partner Danny Bossa. If you want to learn more about the most cutting-edge science-based information in the world of hormone optimization, please like and subscribe. I also invite you to join my other YouTube channel, The Lifting Dermatologist. The link you can find in the description of this video.
Hello everyone, welcome to the TRT and Hormone Optimization YouTube channel. I'm Danny Bossa, joined with my partner, Dr. Steven Devos, and the very talented and super cool Dr. Jordan Grant. How are you guys doing?
Hi, Danny.
Hi, Danny.
Hey, that's good. So, I don't want to say it's another E2 video because I know we've done a lot of these, but it just seems that we've done so many estrogen related videos and there's still so many weird comments. I'm not sure if they're coming from guys that haven't seen videos done yet. I did one with Jordan at one point. We've done one with other physicians as well. People are under the impression that everybody on TRT is using an AI or should use an AI. People are under the impression that most guys need it, or some of them say some guys need it. I'm under the impression that virtually nobody needs it. And we want to do a deep dive into that today. We want to go through as many topics as possible about estrogen, and any studies that are mentioned in this discussion, we will link in the video below so that you can go look at these studies together. You can go look at these studies yourselves, because there are a lot of studies that we've looked at that are just kind of misleading, I guess you could say. Jordan will explain a little bit as to why, and there's some that are just blatantly obvious as, you know, this is the right way to do things. And the other thing too that I need you guys to understand is there's a lot of comments that we get in our videos in the Facebook group and elsewhere about, you know, this is just Danny's opinion. It's a big conspiracy theory. They're fear mongers. They just want everyone's E2 to run rampant and so on and so forth. And the part that I still fail to understand is, and we're gonna discuss this, of course. I apologize for the little rant tangent I'm going on here. Is what possible reason would we tell you to do something if we didn't think it was a good idea? If we knew that blocking or managing estrogen was a good idea, we would say do that. That's best practices. But we know it not to be true. We know that you shouldn't. So we are saying don't do it because the evidence has been demonstrated to us. So we just want you guys to have the right information. If you want to block it, unblock it, you will do whatever the hell you want to do. It's fine. We just want you to have the best information possible. So we're going to go in a fairly deep dive. Dr. Jordan Grant, he's done a lot of reading up on this stuff, and we're not going to go into anything overly technical. We don't want to put you guys to sleep, but we want to make sure that by the end of this video, you've got a better understanding of the role of estradiol in men. So Jordan, let's start from the beginning.
Oh, boy.
Testosterone is the male hormone that everyone calls it, and estradiol is the womanly hormone, right? And I don't want to be a woman. So how do we get estradiol? Where does it come from?
So, and we need to, I guess, first talk about, there's different estrogens, right? There's not just estradiol, but the main hormone we usually want to talk about, the one that's most active physiologically that is natural, is estradiol. There's a couple other ones, estrone and estriol, but they're weak compared to estradiol. And then there's environmental estrogens. So there's a lot of this. It's confusing when people just hear the term estrogen, because that could mean a lot. And that's, I think, where a lot of this stuff has actually come down the pipe from, and we can talk about that later, the studies where they've done on obese men with low T, but they've got high estrogen. They're measuring total estrogens. They're not measuring E2. And that can be from incomplete breakdown of the liver or all kinds of stuff. Anyway, so estradiol, though, it is, female hormone in the sense that, we think of it because of the menstrual cycle and the way in their fertility cycle and all that. But outside from that, and then during development, E2 is pretty much not sexually dimorphic, meaning it affects men and women the same way in a lot of areas, in the important ones that we're talking about today. Some people probably remember this if you went to med school or took embryology, that we all start out female. And then it's actually the androgens that then direct the changes to our tissue. So we all have E2 or estrogen receptors, not E2, but estrogen receptors, androgen receptors. We're meant to have estrogen. So there's a big misconception. I've seen several guys post that, estrogen antagonizes testosterone. And it's like people think of it as light and dark or, good and bad. It's just not. They're complementary. They do different things. And we need both. And so, diving into the papers on this stuff has been pretty fascinating. So estrogen in a man, I'd say about 15% of estradiol is made in the testes. Whenever luteinizing hormone stimulates testosterone and estradiol release. So about 15% of circulating estradiol in men is from the testes. When you're on testosterone replacement, that goes to 0 from the testes, pretty much, unless you're taking HCG, which is a different topic. TRT alone, you shut down the system, shut down LH-FSH, you're not pumping out estradiol from the testes anymore. So basically, your estrogen is coming from conversion from aromatase, which is an enzyme that a lot of people have heard of because they take aromatase inhibitors. So they think they know what aromatase is. I don't know what aromatase is because I've never seen aromatase, but I know what people think it is as far as, science. Aromatase, because I used to have it in my head that aromatase was like in the bloodstream and testosterone is just like, the minute it's getting out into your system, it's just converting over into estrogen and flooding the system. Because that's the mental picture people get. And that's not what happens. And this has all been, it's not new. I'd say probably since the late 70s, they've been talking about something called intracrinology, which is different from endocrinology. And endocrinology is the theory that everything is systemic. The hormones float around systemically and they do their job. And that's how estrogen was thought of for a long time. I think mainly because of premenopausal women and they get the estrogen spike and all that. But I've got several studies and we're going to link to them and they all say the same thing. And this is a big deal is in men and postmenopausal women, estradiol is not acting as an endocrine hormone. It is being converted in the target tissues wherever aromatase is present in different amounts, and therefore it's acting as an endocrine hormone in those cells. And most of it is actually then deactivated or gotten rid of within those cells. A little bit leaks out into the tissues, and that's what you're picking up when you measure estradiol on a blood test. But where do we get it is via conversion from aromatase. And we don't have to talk about the steps involved in that because there's a lot of organic chemistry stuff that I've forgotten and it doesn't matter. And then there is conversion of androstenedione to, I believe, estrone, and estrone can then interconvert to estradiol back and forth a little bit. But the main component is from testosterone or androgens converting into estradiol via aromatase. So in a nutshell, that is where we get our estradiol. And that is probably the biggest point that I need to hit home today, and we'll come back to it probably more than once, is estradiol is made in the tissues in different amounts. It's not the same everywhere. It's not, and these papers mention this, and like I say, you can read them for yourself. Estradiol is not functioning as an endocrine hormone in men or postmenopausal women, but also in men, meaning the serum level is reflective that something is going on in all the tissues, but it's not directive. That tiny amount probably does have a little bit of biologic activity, but it's not anything compared to what's going on inside those cells from estradiol. So the problem is going to be when you block that conversion, you block it in every single one of those tissues where aromatase is present. So
kind of a simple analogy to use would be, imagine a bucket of water and it's got a tiny little hole and there's little drops of water coming out of the little hole in the bucket. And you're measuring the drops of water, trying to determine how much water is in the bucket, which is like, kind of.
Yeah, a good analogy, because I've been trying to think of a good analogy, I'm doing other stuff because I'm a nerd and I think about this stuff all the time. And it's not perfect because it's not dealing with a hormone, it's dealing with a protein, but PSA levels, because I'm a urologist, it made me think about this. Intraprostatic PSA levels are not the same as what you're picking up in the blood. PSA is a protein, and so it's not directing hormonal action. But there's guys where, you'll measure their PSA and they'll have a high PSA. and they'll go, oh crap, I've got prostate cancer. Well, then you put them through a workup and you don't find any prostate cancer. Well, the reason you're picking up PSA in the bloodstream on every man is a little bit leaks out of the tissue. Think of it like a leaky sewer system. A little bit's leaking out and your bloodstream's picking it up. But what that doesn't say anything about what's going on necessarily directly in the prostate. It could be an indicator of something. If your PSA is 0, you probably don't have a prostate. You probably had it removed. But just because you have a higher than normal PSA doesn't mean there's something pathologic going on. It could, but it doesn't. And again, this isn't apples to apples with estradiol, but it's just another way of thinking. The blood levels and the tissue levels are not the same. And, we always get guys, I get guys all the time, and they have an elevated PSA and we ruled out cancer. They say, well, how can I get my PSA down? I'm like, you don't need to. It's not causing any harm. It's a protein. You're just picking it up in the serum. It's not the PSA that's the problem. Is there something going on in the tissue? So not the same as what we're talking about, but I thought that was a fairly good analogy, that there's different levels. And we could make the same with DHT. And all this whole talk applies to DHT. And it's funny how nobody's hardly ever is talking about blocking conversion of testosterone to DHT. I mean, they'll do it when they're worried about male pattern baldness. But other than that, they don't measure DHT. They're not worried about it. It's the exact same thing as estradiol. It's more of an endocrine hormone, meaning it's made in target tissues from 5-alpha reductase conversion. If you look at intraprostatic DHT levels, are massive compared to the serum DHT. I've got a great study where they gave men different levels of testosterone, didn't affect the intraprostatic DHT levels, because these endocrine hormones, they're very tightly regulated. And it's the same with estradiol and aromatase and all that. So I just wanted to kind of try to give an analogy. I tried to think of another one, but I couldn't think of anything much better. I'm sure we could think of plenty, but it's reflective. Okay. It's basically that serum level that you're measuring on a blood test, a sensitive, sensitive E2 level, is just showing you a glimpse that, yes, you're converting to estrogen in your tissues. That's all it's basically saying. Now, if it's really low, that might mean you're not making enough. If your serum E2 is like 5, you're probably on an aromatase inhibitor, or you have some kind of congenital deficiency, but not necessarily. I think there's probably guys that run a low serum E2. Let's say they're super lean. They're not making estradiol in their adipose tissue. So they're not putting out as much in the serum, but they still may be fine in their other tissues. If they feel fine, they're not having the symptoms of low E2, probably fine. So it's all pretty fascinating.
The whole talk that people used to say, that I remember way back in the bro science days of stuff I was reading, I was convinced that low E2 symptoms were very similar to high E2 symptoms, meaning erectile dysfunction, low libido. Well, it could be either one. And I remember always being in this position like, well, am I taking too much Aromatase? Am I taking not enough Aromatase? And I have to go get it measured because I got to find out, because I got to keep it in this range. And it was just maddening. So we tell guys that it's good for us. And I guess the thing that men have a hard time with is like, how the hell could estrogen, or I know we're talking about estradiol, but I'm going to say estradiol just to be politically correct for this talk, but how could estradiol, which is known as the women's hormone, possibly be good for me?
Right.
I don't know if it's just what it's called, because we know that to be the women hormone. Maybe if it was called like the Johnny Badass hormone, like nobody would think about, like I want some of that. I want that hormone. Maybe it's just because estrogen, isn't that the woman stuff? Like, no, I don't want any of that. So what are the benefits in the body that you can list? Because I know I can list a ton, but
I've got some stuff pulled up over here, and the key to, you got to look at these studies and figure out the best way that you can interpret them, because there's different ways studies have looked at estrogens and what they do, and they'll do petri dish studies, and they'll do these things with synthetic non-bioidentical estrogens. That's not relevant. The best studies that we could really do to look at this is to look at what happens in humans when they don't have aromatase. And then you can really find out what are those estrogens doing. And so they've actually done studies in mice, on aromatase knockout mice, where they've knocked out the gene encoding for it. And then what happens? There's a few people who have congenital aromatase deficiency, and those are ideal people to look at. The other people to look at are comparing two groups, men on TRT versus men on TRT with an AI. So all that's been done. there's a great paper that we're going to link to. It's probably the #1 paper that people should read first. It's called Estradiol as a Male Hormone. It's fantastic. I think you originally posted it on the group a long time ago. But it gives the references are great at the end because it links to all these other great papers as well. So be sure and always look at the references, when you're reading these papers. But just briefly, not just benefits. I mean, the estrogen does different things. We don't have to talk about what it does in reproductive tissue. Most of us are past that point of worrying how it affects spermatogenesis and all that. Interestingly, E2 seems to be the primary driver of growth hormone secretion, which I thought was pretty fascinating. There's been some talk about it increasing IGF-1 levels in the liver. A lot of people say that. The studies I've seen, I think it changes the response of GH to IGF-1, but I don't know that it actually enhances it. It actually helps with insulin sensitivity. So they've done all these studies on guys on AIs or aromatase knockout or whatever, and much, much worse insulin sensitivity is a big deal, especially in skeletal muscle. So you see people with worsening blood glucose parameters, things like that, when they take AIs for a long time, or if they don't have aromatase at all. Bone is a big one. This is the big one that they, eventually started seeing in women on aromatase inhibitors when they had breast cancer. Bone mineral density loss. I think men, it takes longer to see that. It's not just going to be a few months on an aromatase inhibitor, you're going to start losing bone. But there's several papers that once they go long enough, you do see that change. And then they have all the markers of the bone turnover and all that. Androgens in men are also protective though. So men probably aren't going to have osteoporosis as bad as women, even naturally, because androgens directly stimulate bone as well. So when we see it as urologists, when men have to be castrated for their metastatic prostate cancer, they lose testosterone and E2. I know there's all these studies saying these old men have low T and high E2. No, they don't. They've got low both because you get your E2 from testosterone. Anyway, so that it's a big deal with bone health. And I've got a good paper we'll link to on the intrachronology of androgens and estrogens in bone tissue. It's pretty amazing. And something that needs to be said is, and this is just one paper mentions this, the E2 levels in bone compared to the blood are only about 50%. So they're half of what you're picking up. So there's some tissues where E2 is like magnitudes greater than what you're picking up in the blood. And there's some like bone, it's not as high. But again, what happens when you block aromatase? You block it everywhere. So the tissues where it's super high and you block it, and maybe that's not as big of a deal. Probably is because it needs that much. What about the tissues that only has a little bit and it goes to zero, like the bone, So bone health is a big one. Body composition, this is huge. I'll try to find the papers on this to link to as well, where they studied aromatase and adipocytes and different fat patterns and all that. But it seems like estrogen actually helps increase leptin. Leptin has been a big topic the last few years. People, when they diet, their leptin levels fall. Leptin is kind of the master metabolic regulator, or one of them. Hunger hormone as well. And people on aromatase inhibitors have lower leptin levels, worse insulin resistance, and increased visceral fat. So they've seen when they add back E2, you have more visceral fat loss. And visceral fat's the bad fat. It's the fat around your organs. Usually a sign of also insulin resistance. So these probably all go hand in hand. It's almost like low E2 leads to metabolic syndrome.
So someone who's got visceral fat, blocking E2 is probably the worst thing they can possibly do.
Absolutely.
That's the thing that's going to help them get rid of the damn visceral fat.
Yeah. Now, and subcutaneous fat, just, in places, that's more down to calorie balance than anything. You're not going to all of a sudden take estrogen and then start developing fat. It's different with females because their fat patterns, that's stuff that was ingrained, a lot of it's genetic, and I guess over time, if you were taking a high amount of E2 as a man, you might start seeing some changes in fat pattern. But we're not talking about taking E2. We're talking about letting your body make the amount that it's supposed to make. And that's a huge deal because people are like, oh, Jordan Grant, he loves estrogen. He wants everybody to take estrogen. And I've never said that. So no. That's not what we're talking about.
We're not telling anybody to literally take estrogen, guys. But there are some, like Jordan was saying, that they don't make enough of it. And we do know physicians that are actually prescribing estradiol to ensure they have healthy levels.
Yeah, and I've heard Dr. Rouzier, I think, when he talked about this on Jay's podcast, whatever that was, over a year ago, that there are, I mean, cardiologists he knew that were taking estradiol to bolster their levels. And I'm not the one to speak about that because I don't do it. When I give E2 is for a man who's been castrated and is having hot flashes and bone weakness and memory issues. And you do it what's called like E2 add back. And there's studies on this and it helps libido. So here's another one with E2, drives libido. I know that people think that's crazy, but it does. They've done tons of animal studies on this, and it's really interesting with like mating behaviors in birds and all this stuff. But it's the same in men. And there was a good paper I'll link to as well about men who've been castrated and who have been given estradiol to help with their libido. Interestingly enough, so I learned this in residency, and I didn't really fully understand the mechanism. Whenever in the older days, when a man would have prostate cancer metastatic, you could either give him an androgen blocker, so basically something to block the receptors, or you could castrate them, which is two different things. They'd always say if you give them the estrogen blocker, it would preserve their erections or their libido. And I thought, that doesn't make sense. You're blocking their testosterone. Well, the reason it works is because you're given the negative feedback loop. You actually start pumping out more LH, FSH. Your estradiol levels stay high, you're not blocking those, and your libido is preserved. Whereas if you castrate a man, you remove his testicles or chemically castrate him, he doesn't make E2 or testosterone, and he loses the libido. So pretty fascinating that, even in residency, they said this stuff and you read it, but I didn't know why. But it makes sense that estradiol is a big driver of libido. And so the other thing, we talked about glucose metabolism. Brain health is a big one now. I've got a good paper I posted recently on that one it's amazing, the endocrinology in the brain. Basically, estrogen is acting like a neurosteroid. Found aromatase in the synapses, just where the neurons meet and talk to each other. So you're making estradiol right there on the spot from circulating androgens. And all this stuff is important in cognition and memory and verbal memory. There's different kinds of memory, things they've looked at, but they worry about low E2 and Alzheimer's in women, all kinds of stuff. So those would be the big ones. I would say would be sexual health, bone health, metabolic health, neural health. Those would be the big ones in my mind. And when we start blocking those, you start seeing issues. So
a lot of guys, what they believe is they said, well, yes, this is all, a lot of bad stuff will happen by blocking estrogen, because I know when I crash my estrogen, I have no libido and no erections and on and on and on, but I find that when I have too much, then a lot of these things happen. And that's, they say, I want to keep it in this range.
yeah.
You want to maybe just touch on that about how some of the guys are just not really giving their bodies the time to balance out, that it could sometimes be an issue with protocol.
Yeah. There's no good studies on this part of it. Number one, let me back up and say there's no studies showing that men should block aromatase on testosterone replacement. None. That should be done. That's a standard thing. Doctors they love their lab ranges, and so they would check. People started checking estradiol. Well, if it goes out of the normal range, what do they want to do? They want to fix that, and so people get fixated on that as well. The reason estradiol goes up when you're on testosterone is because you have constant levels of testosterone. So there you have more aromatization going on. You're going to pick up more E2 that way. Whereas when you're making your testosterone naturally, you get these small pulses throughout the day. And so the total sum estradiol that you're going to pick up in the blood is not going to be the same as when you've got a constant androgen load. So of course the range is meaningless because the ranges they got were not based on men on TRT. So again, but people see that number and they think I got to block it. And then there's been the misconception about estrogen symptoms, high estrogen symptoms, things that just aren't really based in reality. And so then when they see a number that's high and they're having certain symptoms, they blame it on estrogen. What I see anecdotally, because there's not good studies on this, and we see it in the group all the time, and I've seen it in practice a lot. A guy he's either been given an AI from the start by a provider, and he never got dialed in that way, and he's been just on a roller coaster ever since then. Or a guy who's been put on testosterone replacement, but never allowed to get symptom-free. He's never allowed his levels to get high enough, or he's been on a horrible protocol of like an injection every 2 weeks, every 3 weeks, once a month, something insane. So they're doing these fluctuations, and they blame it on the E2. and they've never been dialed in. The same way I see it, and I know a lot of people love their HCG, and I think HCG is great to maintain fertility, but it can cause weird fluctuations. And a lot of these guys that have these issues that feel like they need an AI are often on HCG as well, especially some like big dose twice a week or a huge dose once a week. Something interesting about HCG is it will spike testosterone about 24 hours after after administration. It takes 4 days for E2 to catch up because that's coming from the testicles. Your testicles are producing that. It's not the same as aromatization. And so you could get a mismatch there where then, yeah, E2 may be more acting like an endocrine hormone at that point because you're kind of flooding the system all of a sudden with extra E2, and it may be hitting receptors that in the testosterone's already done this. And so, I mean, I don't know. But from what I've seen anecdotally and what we see in the group is these guys have never been dialed in. And almost every scenario, there's always an outlier, but almost every scenario we've taken a guy and said, you got to come off your AI. You got to trust the process. You may have to increase your testosterone, but don't do anything at first. If you're already on a decent protocol already, but you still don't feel well, get off the AI, give it 4 to 8 weeks, see what happens. And we've got testimonials on the page, and I've got patients that will confirm this. They feel great. They feel better than they ever have. I had a guy in town recently. He was on pellets for 10 years and an AI once a month. Like he never felt great. I mean, and he had already stopped his AI about a month before he came to see me in clinic because I think he saw one of our videos. And we got him off the pellets on the injections and just checked his first lab results. He's a little high on his testosterone because he's still got some pellets in there that are dying off. But he said, this is the best I've felt in 10 years. I mean, he feels amazing. And when guys stop, the mind is the most powerful thing. So when they're fixated on that estradiol number on the serum, they're going to convince themselves that they need an AI. Well, we just kind of went through about the serum levels and why they're really not valid at all as far as showing what's going on at the tissue level. So if you can get somebody away from that, and that's the biggest reason I'm hammering this, is because you've got to get away from that blood level. I don't even check it on my patients. I mean, it's not important because it's not showing you what's going on at the tissue. But these guys that they reach for their AI and they'll never give it a chance. You know, they'll say, oh, I tried to stop for 2 weeks, but then I started feeling weird. Or I got a little nipple sensitivity. So they grab their AI and then they felt better for a day and then they start feeling worse again. It's a never ending cycle. You see it, Stephen sees it, we all see it.
So why is there an upper limit on lab ranges for estrogen? Are there any studies that show symptoms from high E2?
I have not found any, and I will gladly take correction. And by E2, I mean actual true E2, not a lot of the old tests that were done. And these are when they used to say these old fat men with low T had high estrogen, which doesn't make sense based on our paradigm here, right? So thankfully this paper brings that up, and there's 2 good papers where they actually went to look and see if it was true, and they found one was in older obese diabetics and another one was just in obese men in Europe. And they actually measured sensitive E2, so an actual, not a immunoassay, but a liquid chromatography mass spec lab, and their E2 levels were not high. So no, I haven't seen any studies where physiologic E2 made from aromatization with men on TRT, there's ever some level that causes symptoms. Never seen it.
So as Danny said, the low E2 symptoms would be the same as the high E2 symptoms, but that's really bro science, right?
It is. And if you Google it, everybody does it because I used to do it. You Google high E2 versus low E2 and there's a little snapshot there and people will copy and paste that and put it in the group. And I'm like, yeah, your Google search is meaningless because that stuff's not based on any science that I could find. But it's passed around in the bodybuilding forums. I mean, you just got to keep it in range because, you could be having these symptoms either high or low. No, it's not. It's totally different. When you're low, you're low. I've been there. It's horrible. Danny's probably been there.
Oh, but we talked about that last video we did of how we were obsessed with trying to keep it in this range, and we're never always wondering, are we too high? Are we too low? Or do we have to take more of the AI? How do I time my AI? Do I take it before the injection, a day of, or do I take it the day after? And it just never worked. And the funny thing, guys, something you got to understand, it took so much arguing with me. You know how stubborn I am, right? People arguing back when I thought AI was needed. And I used to argue with the doctors I had in the area. to say, no, I need an AI because otherwise nothing is going to work. And I argued with them to death. And eventually somebody convinced me that I shouldn't. And I say, you know what, I'm going to try it because so far nothing else I've done has worked. And as soon as I stopped, literally as soon as I stopped, within a couple of days, I felt those E2 symptoms happening again. And right away, I'm like, see, they're full of crap. See, I got my little gyno here that's starting to swell up, and like my little friend down there is not working so good, and my lipo's off, and I don't feel the same. And oh, see, I should take my AI. I say, you know what? If I'm going to do a test, let me at least do a proper test, and I can wait and see how horribly wrong things go over a period of time, and then at least I can report back and say, see, you were wrong and I was right. Mm-hmm. And it was just like things started getting kind of off. But then they kind of plateaued. And like with every passing day, I was always about there. And then it just started getting better and better and better. And then it was gone. But then when I felt back to my usual self, if you will, then I had days of improvement. Like I'm feeling better than I was on the AA. I'm feeling better. I'm feeling better. Guys also watching, it's not just a question of feeling better. I feel better when I'm on an AI. There's some reasons why some of you will feel better on an AI, okay? It doesn't mean that taking it is healthy. Imagine I could tell you that you can dial in your protocols better, that you won't need the AI. You'll feel as good as before, if not potentially even better, just by some small tweaks. Because it's good to say, well, it works for me because I feel better. I used to smoke half a pack of cigarettes a day. I quit, 2 years ago, okay? I used to smoke half a pack. And I felt great smoking those cigarettes. We know damn well that cigarettes aren't good for you. We know damn well that AI use is not good for you. Yeah, you might feel great now, but down the road, things are going to happen.
I totally agree. And that's a big, because we harp on symptom resolution and feeling good. And that doesn't mean euphoric all the time. You can't trust your feelings. We all know that because that gets us into a lot of trouble in life by trusting how we feel.
Yeah.
They're not really trustworthy. And especially when it comes to, I'm not saying ignore symptoms and all that stuff. That's no, not at all. But, there is a mental component to the AI. It is more powerful than I ever realized until I joined the group and started really interacting with men about this. And it's literally like cocaine or crack. I mean, it really is. Like I don't know how many guys have messaged me saying, I reached for the AI again and I did it again. And it's unbelievable. I mean, it really is. It's that powerful because they have been just hammered to believe that they have to keep that estrogen in a certain range. And it ruins their lives, honestly. It really does. And the best thing they can do is throw that AI away and not check their estradiol levels because they're not that important. They're not driving the action in their system. Your body has an amazing way of balancing the testosterone it's given and the metabolites it needs, meaning both DHT and aromatase. It's very rare to have aromatase deficiency. I've only seen one case report of somebody with overexpression of aromatase, like too much. It's not like, but most guys think that they're in this, like, I'm an over aromatizer. I hear that all the time or see it written. Yeah, I'm an aromatizer. Yeah, you are. We all are. We need it. Like, that's the point. They're like, but what they mean, they mean over aromatizer. Yeah. No, you're not. You're not an over aromatizer.
Guys, the instance of this occurring is so tiny. It's probably 1 in 10,000, maybe even 1 in 100,000 that has a variant where they're just converting an insane amount of test to T2. And for them, yes. The problem is that all you think, oh no, but I'm an over aromatizer, just as Jordan was saying. And you should see the posts that we get in our Facebook group. Guys, if you don't know what Facebook group we're talking about, it's called TRT and Hormone Optimization, just like the YouTube channel. Guys coming in saying, I've tried this, I've done this and this. We've suggested some really minor tweaks to the protocol, and they get off. And then Jordan and Stephen, we're getting all this thank you emails saying, hey, I feel better. I had, my erection quality was so, and now it's perfect. Or I wasn't able to sleep before, now I can. Or I had brain fog before, I felt good about brain fog. That's gone, whatever it is. And you got to understand that I have nothing to sell you guys. I have nothing to sell you. Like this, I want you guys to feel good. If feeling good meant taking an AI and controlling that estrogen, that is exactly what we would be reporting. Okay?
Well, if it was healthy, if it was needed, I mean, that's different, but it's not needed. I don't know what I was going to say. Something really passionate.
I'm going to show them the screenshot of that poll. Okay.
Yeah.
Guys, I made a poll in our group. Now in our group, we have a little over 2,000 members right now. I was curious because a lot of people were saying, you know, all this, no, you anti-AI guys and stuff like that. Like most doctors prescribe AI right on the spot. Most guys are taking an AI, so on and so forth. I made a poll, and the poll was, you have 4 options. Either you never took an AI, you took an AI and stopped and feel better. You take an AI now because you need it, you feel you need it, or you want to, or you tried to stop taking an AI but just couldn't do it. Okay, I'm going to show you, this is a current screenshot of the poll. Okay, so if you look there, you're going to look at the first option, never took an AI. There's 140 votes so far for never took an AI. Took an AI, what's the second one? And stopped, and now I feel better. 97 people selected that one. Take an AI now because I need to or want to, only 18 people. And then the other one tried to stop taking an AI, but I couldn't do it. There's only 2. So you can see right now, and again, this, I understand this is in our group, but the vast majority of them are not taking an AI and are doing great. And most of them have learned that in the group. Now, if they came to our group and we were telling them not do this, and they were doing it and it just wasn't working out, or they get it worse, they'd say, hey, I tried and it didn't work, or whatever, or no, I take it. It would be demonstrating. And right now, this poll, for me, is evidence that what we're doing in our group is working. There's more and more guys getting off this stuff. Not to mention, it's not only Dr. Grant and Dr. Devos that talk about this stuff. Literally every single doctor that we've had on this channel has said the exact same thing. Even IFBB pros we've had on, John Meadows and Greg Doucette, who obviously go more beyond TRT, you know, stuff that they take, they're not taking AIs. They don't do that for any of their clients. The medical professionals who come on, the functional medicine practitioners, they just don't. So we're talking combined tens of thousands of guys, no AI, doing great. So the question is, ask yourself, why would we be telling you this if we have nothing to sell? We're telling you that if you're on an AI now, number one is, if you're taking a weekly injection and feel that you need an AI, try splitting that injection up maybe twice a week, because we should actually go into that, Jordan, of how what they consider to be E2 symptoms, high E2 symptoms, are typically just caused by these fluctuations. And it's my understanding that when you're taking an AI, it'll kind of minimize those fluctuations. So yeah, you're going to feel better, but you're causing harm in order to feel better. And that harm will catch up with you after a while. And the other thing is, there are some guys that potentially are not taking enough testosterone that, you know, they just need to have, when you're taking testosterone, you take an AI, well, now less is converting into estrogen, which means you wind up with a little bit more testosterone. How much that is probably negligible, but you still wind up with more testosterone. So guys are not taking enough. Yeah, any little bit is going to help. I've noticed with myself and like virtually every single guy I've helped out, again, for free, just in my spare time, and Jordan has in the group like crazy, is we look at their labs and we're like, what are your symptoms? Your symptoms are this. Try a little bit more testosterone, get rid of the AI and see. And they always come back like, yeah, that did it. Yeah. Most of them are either taking an AI, not feeling good, or they're doing weekly injections, not feeling good. Some of them might need twice weekly. Sometimes
or they're on
3 times.
Or they're on HCG, or they're on HCG and DHEA and pregnenolone, and I mean they're loading things down. There's so many variables in there. It's really hard to. And I'm a big stickler for simplicity, and I like dialing guys in on testosterone alone. I know there's doctors that say you got to start taking DHEA and pregnenolone right away. The more I look into, especially like this intrachronology stuff, don't know that I see as much benefit in the supplemental side of those unless you're truly deficient. Once you're kind of tanked up on them, adding a lot more may not do that much actually at a cellular level because your body's already taking care of that. We'll go back to what I was going to say earlier. Why is it when guys are pumping out natural levels of 1200 and 1500, they're not told they need an aromatase inhibitor? Why all of a sudden when you get on TRT do you immediately need it? Every one of these big box TRT clinics across the country, they do it, you know, and there's a cookie cutter protocol. It's, here's your testosterone. I want you to take this. I want you to take HCG, and I want you to take your AI. And they sell that stuff. So yeah, they do have something to gain by it. I'm not knocking those clinics. I mean, at least they're getting guys on testosterone versus the doctors that refuse to do it. But that doesn't mean it's okay that what they're doing either. You know, it's in my mind, it's not, if we know that it's harmful to do stuff and you still do it, not the best interest.
It's like they're anticipating there's going to be a problem. I'm going to give you
it's going to save them
protocol. Yeah, and I know you're going to have issues with high E2, so let me give you this aromatase inhibitor.
Yeah, they'll implant that in their head. It's like Inception. You know, they're like implanting a dream within a dream here. Yeah, you got to watch that E2, or you're going to have this, this, and this. And then they'll see in their lab and go, gosh, my E2 is 45, and it's supposed to be 40. And yeah, I'm not feeling right. I got to pop an AI. I mean, it is just like that. Mm-hmm. And then you were talking about the protocols and the weekly and the fluctuations. I definitely think that's a big part of it. Is poor protocols, not getting stable levels. It's not just E2. That's just in general. If you're fluctuating with your testosterone and then you're fluctuating with the other metabolites that you need. It's not just the estrogen. It's the DHT. It's the testosterone. You're doing this. And for whatever reason, when you replace testosterone, it needs to be fairly stable. Why that doesn't cause an issue when you're natural and pulsing testosterone all day, I don't know. I have no idea why then it's okay. But that's how the body is an amazing thing when it's doing what it's supposed to do. Because it just constantly pulsing. I mean, you're literally going from high T, but you'll go low again pretty quick. If you didn't, you'd shut down your own hypothalamus. But you go low enough that your hypothalamus is like, oh crap, we got to pump out more.
Yeah, but how much of that up and down is going to be? It's probably a fairly narrow range, right?
I don't know.
It's like keeping a thermostat between 21 degrees and 23 degrees, and it'll
highly regulated. Yes, and it's just fascinating to me though that it's that you don't shut your own production down. I mean, there's negative feedback, and then an hour later, oh nope, now we need some more, you know. But you just take a little bit. I mean, there's guys that take 100 milligrams a week, not much at all, and it still shuts you down. So I think it's just that constant stimulation. You're not getting the pulsatile nature. It's the same reason LHRH agonists. So we're going to go one step above to the hypothalamus. So like Lupron, which is what they give guys to chemically castrate them. If you pulse it, it will increase their testosterone. If you continuously give it, it will shut down their system. So I think it's the same thing. When we're constantly giving testosterone, that's what causes the shutdown. Anyway, that's a tangent, but the fluctuations I think matter, and I think that's a big deal with HCG. I think if I see a guy who really wants to be on HCG because of fertility or just has to do it, I do think smaller doses, even daily, of HCG would probably be ideal for them. 150 units a day, something like that, just to keep things nice and stable. Because things will equilibrate if you're doing daily. Eventually, with those fluctuations with HCG, it'll kind of smooth out. If you're doing a couple shots a week, you're constantly doing this. Even if you got testosterone dialed in, you're adding another layer of fluctuation with HCG. And then with aromatase inhibitors, you take even one time, and it causes these fluctuations, and then you rebound after that, depending on the AI that you take. Another thing we probably should touch on is, because we do have people that take steroids, and they're taking DHT compounds or derived compounds, or they're taking nandrolone, and those also interfere with aromatization. And so that's something really important that people need to know. DHT is going to bind aromatase, but it can't be aromatized. So it's basically, competitively inhibiting aromatase, acting as an AI. Not probably as strong as Arimidex or Aromasin, but we've seen it in blood work on guys, and they need to be aware of that. And that's a case where there are coaches in bodybuilding adding estradiol to their guys' cycles. And that's smart. Those guys, I don't think they still understand this side of it that we've talked about, this paracrine, intracrine system, because they still talk about the blood levels a lot, but at least they understand the importance of estradiol. I mean, that's a big breakthrough in the bodybuilding world. They still are fixated on estrogen and gyno, which we've talked about, and we don't need to rehash today, but I'm sure somebody will bring that up in a comment that, estrogen causes gyno. No, estrogen alone does not cause gyno. If you give estrogen in a setting with perfect androgen balance, it's not going to cause gyno. There's an imbalance issue there. There's IGF-1 issues, prolactin, blah, 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 genetics. There's tons of, factors involved with gyno. And you personally can attest to that. I personally can attest to that. When I got gyno, my estrogen was not high. I was actually taking Aromasin at the time, and I was taking MK677 at the time, and got a gyno low, So
And mine was even long before TRT. Guys, just in case you never saw the video we did, I had mine probably 15, 20 years ago. And when I finally got blood work done, my E2 was 12. So 12 for E2 is really low. They say that the magical range is 20 to 30, which we're explaining here is kind of silly. I was 12, so I was incredibly low, but I had very low levels of testosterone. I feel that I developed my tiny lump simply from a testosterone deficiency, because as soon as I brought it up, my estrogen came up, and then suddenly it started shrinking and shrinking and shrinking, and now it's less than half that it was. I'm going to post some before and after pictures on my Instagram, which I hardly use, but I think I should start using it for this purpose.
Yeah.
The difference it made. I want to touch on two little points really fast. Something you said. Guys out there, I'm sure you know at least one super jock guy. He's not on TRT. He doesn't take gear. He's just, just oozes testosterone. He's just built like that. I know a bunch of guys like that myself. They have naturally high levels of testosterone. Okay. I want you to think of the guys that you know like that. Now go see those guys and ask them, are they taking an aromatase inhibitor to block the estrogen that they're making, the crazy amounts of estrogen from all this high testosterone they're making naturally? No, they're not. You don't know guys that are just walking around, I'm just going to take an AI. It's just not done. So how is it that when guys on TRT get our levels up to what those guys are, well, suddenly we need to block it? It makes no logical sense. And you really need to ask yourself these questions to wrap your brain around that. Blocking it is just silly. All right. There's nothing but benefits from estrogen. And if you block it, even if you just block it a little bit, we're going to block those estrogen benefits just a little bit. And over time, that blockage is going to cause an issue.
Yeah.
In regards to very quick. And in regards to the fluctuations that he was mentioning, if you're taking weekly injections, you could say, you know what, let's say I'm taking 200 milligrams a week. I'll split it in two. I'll take 100 twice a week. Let me try that for 8 weeks. Do I feel better? Yes. Great. Stick with that. I don't feel better. Okay. Try every other day. So take your weekly dose, split it into 3.5, and then every second day, take a tiny dose. Try that out for about 8 weeks. Do you feel better? Great. Stick with that. You don't? Let's go to the more extreme. Take your weekly dose, divide it into 7, and take a tiny little daily shot. We know guys that have to do daily just to keep those levels stable. And as soon as they do, everything is fine. And I've got guys reporting back to me like that they're trying like really high levels of tests just for an experiment of their own, because a lot of these guys we talked to are kind of like biohackers. And they're saying I can go up so high, and as long as I'm doing daily, I don't get any of these E2 symptoms, because they're not E2 symptoms. They're the fluctuations. So doing daily, whether with injections or the daily cream, is just going to keep your levels just totally flat. You won't have these issues at all, and you reap all of the benefits that estrogen is giving you.
I was going to say, there could be certain men, they get gyno when they're younger because they do have an aberrant aromatase expression in the mammary, tissue. I mean, just like women can have, that's an issue with the tissue. You know what I mean? That's not the estrogen necessarily doing it. They're overexpressing aromatase. That's seen more in cancers than it is in normal tissue. And that's
I had that myself.
Yeah.
As a teen, it was a lump that formed like a marble out of the blue. And I was super, super, super lean when I was a teen. And I remember being able to grab it and pull.
That's usually
showing my mom.
Yeah, and that's usually not from aromatase. That's usually the teenage, pubertal gyno. That's when you really start getting into these weird fluctuations with GH and IGF-1 and just, your typical growth hormones, and they're all out of whack, out of balance. And once things get balanced out past that period, a lot of times those lumps will go away and they're not permanent, which is a little different from like a steroid-induced lump that is probably permanent, but it can still shrink. Like mine has gone down. I can still know it's there because I know where it is, but you can't even really see it through my t-shirt or anything like that. What else was I going to say about you were talking about just blocking it a little bit. I mean, that's the thing. Guys will say, well, I just want to block it a little bit. Why?
Why?
What?
To accomplish what?
What evidence? We've already talked about these serum levels. Like, this is a big deal. And I want people to look into this. Read the papers that we post. I mean, look into it yourself. I'm not making this stuff up. When I first read this, I was blown away. It was, to me, this is a paradigm shifting thing. To the endocrinology thing changes everything. I already knew we shouldn't be blocking it. I didn't really understand why, except that it just doesn't work and you feel bad and you have all these bad side effects. But once you realize where estradiol is actually made and that measurement you're getting in the blood is not telling you anything about what's actually going on, then it's like, all right, I'm done. I don't need anything. I don't need to know, you know? And I'm sure there's gonna be all kinds of questions and people talking about, well, estrogen causes water retention and estrogen does this. And I think we can talk about that as they come up, because they've done, studies on women during their cycle and what the hormones do to water retention. That's not relevant here to aromatized E2. Androgens cause water retention. You know, people don't get that. They stimulate the kidneys directly, probably as much as E2. E2 doesn't actually stimulate the kidneys much at all. It can change the ADH set point, but anyway, it's minimal. It's just there's a lot of stuff that's blamed on E2 that's not E2. You know, a lot of side effects people get when they're too high is because they're too high on their androgen load. It's not because their E2 is too high. And that's what I think we wanted to bring up. Did you want to talk about that here at the end, the graph where they gave the steroid, or not steroid users, but the guys up to 600 milligrams a week of testosterone?
Absolutely.
So I think I don't know if it's Bazin or Bossa, Basin, the big study. All the bodybuilders quote it because they know it by heart, because it was a dose response thing where you get more testosterone, you grow more muscle doing nothing, sitting on the couch, you know, and they did it up to 600 milligrams a week. Well, they've got lovely little charts in that study plotting the total testosterone levels and the E2 levels in young and old men and DHT. And do you know what happens in both young and old? As the testosterone goes up, 3,000, 4,000, huge amount. You know, usually 3,000 or 4,000 is the limit with 600 milligrams a week. E2 and DHT start doing this. They plateau. So and there's outliers on the scatter plot. There's a few here and there that are, but it's not what people think. They think, oh, the more testosterone I take, I'm just going to keep pumping out more and more estrogen. No, you've already pretty much saturated your aromatase and your 5-alpha reductase at a certain level. Then you start going the wrong direction with too much of a androgen load versus you're not getting balanced with the other thing. And again, people can have issues from that, probably health issues. So there's a sweet spot in there where it's more linear that seems to keep that balance. But again, this is just based on serum levels that don't mean that much. But I just think it's fascinating that you can at least see, just based on the serum levels, that it's not doing what people think it does. I don't put much stock into it because I'm not that worried about those serum levels. But that gives me more ammo to say you don't need to worry about it, because look, even if you are worried about the serum levels, they're going to level off. You know, they're going up linearly to a point and then they plateau. So it's the opposite of what people think. So I thought that was pretty
People
awesome.
are talking about ratios, that you have to have testosterone and estradiol in a healthy ratio. And we do have a paper, and I know we posted it in the group. We can probably throw that in the link as well, that say, for example, you take an AI, so now you're going to lower estradiol, your ratio gets bigger, right? We have literature to support that higher ratios themselves will cause issues. And the only way you're going to have a higher ratio is by bringing the estradiol down. Yeah. The smaller the ratio, the more health benefits there are. So as you're raising T, let E2 follow and have it keep that balance.
It's not the ratio, because again, the serum level is not what's driving it. But when you block E2, that level falls, and that's just reflecting that you're blocking E2. Well, of course, we know the issue is not the ratio. You're blocking E2. E2 is beneficial. Like, I've got studies showing guys on aromatase inhibitors with testosterone have much worse endothelial function. They got worse damage to the lining of their blood vessels. I mean, on and on and on, all this stuff. It's like, it just makes sense. It's all the stuff we see every day. It's right there in the research. But yet guys still want to pull these crappy association studies out where they're like, all these guys with low T and they're high estrogen and they're associated with blah, blah, blah. Like, that's not E2 that they were measuring. And the papers that we have where they did measure it mention the old papers saying they didn't use the right lab. So
and we're going to do a video on those studies, aren't we, Jordan? And a separate
we're going to talk about a lot of stuff. So, but anyway, this is just more broad.
My point was people obsessing with this ratio thing. Yeah. And there's literature to suggest high ratios, whatever, but you're still using the measurement of estradiol, which isn't even really a measurement because of, what you're saying, it being an endocrine hormone. Right. That we're just measuring a little the little bit that's winding up into the
you're
serum.
getting
So
a muddy, what I've been saying is kind of like you're getting like this muddy reflection of what's actually going on at a deeper level. It's not, it shows that something is going on. Yeah, it means you're making estradiol in your tissues. Good. Doesn't tell you how much each tissue is getting. Each tissue is not contributing like an equal weighted average to that level. You know, that's what I always tell guys. They're like, well, but what if my fat cells are making too much aromatase, or, you know, and they're pouring out too much E2. And I'm like, well, what if they are? If you block it, you still block it everywhere else that you need it. Like, it makes no sense. The other thing we were talking about, we didn't mention it, aromatase in fat cells. Like, people used to think that that caused obesity. No, it seems like it's actually a response to try to keep the metabolism of those fat cells doing what they should do. It's actually a good thing that they make aromatase. So anyway, it's a huge topic, but I just wanted this to be a big, broad picture, you know, of how it's made, what it does, and how the measurements aren't really that reliable as far as tissue action. I think that's the take home point that just a few people can get, because I've said this to a lot of guys and it's like, so what? They don't get it. But to me, it was huge. Like, to me, that's a game changer. Just in the way you think about it. Because like I say, we always think about it just converting out in the ether in your bloodstream, and it's just wreaking havoc and converting. It's not doing that. That's not how it works. And it's the same with DHT, by the way.
to the guys watching this video, I just had a little thought, do something a little bit different. Like I said at the beginning of the video, there's a lot of you saying this is just a big conspiracy theory and it's fear mongering and it's the anti-AI cult and so on and so on and so on and so forth. I want you to think just for a moment what possible reason we would have to give you inaccurate information and explain it in as depth as we've gone. And we're going to go into even more depth in another video. Why would we do this unless we thought it was correct? Now, if you believe that it's a conspiracy or we're lying to you or we're making it up, I want you to comment in this video and say exactly what reason we would have to be doing this. They are doing it for the anti-estrogen dollars from the Department of Anti-Estrogen, or they're doing it for, like, tell us what the reason is and maybe we can clarify it, because I can't understand what reason you think we would have to lie about this, as we don't have a product to sell you. We have no product to sell you at all. We don't care.
I always tell guys, like, I'm an employed physician. I'm not making extra money off commissions or any of that. And I don't spend hours of my free time looking into these papers just for kicks. I mean, I want people, myself included, to know the truth. And I say truth with science is not going to give you truth. It can just point to things that are more likely. And once enough things are repeated over and over, you can kind of get an idea that there's a pattern going on. And that's what we see with aromatase inhibitor use. The pattern is not good. It's unhealthy. I feel like crap. I can't get erections. I can't sleep. My bones hurt. My joints hurt. I got brain fog. I mean, and it doesn't matter what the dose is. It can be, I take 0.0008 tab of Arimidex every 10 days, and I still just don't feel, it's like, why are you even doing that? I mean, I've seen that recently. Yeah. I said, this makes no sense physiologically. Like, once every 10 days, what are you doing? Just throw it away. Anyway, but yeah, we're not out to get anybody with this. If the data comes out and they do some awesome interventional studies, and all of a sudden guys on AIs actually end up healthier and whatever, we'll change our tune.
We'll report that.
Yeah. So far, I mean, everything's pointing the other direction. So we kind of got to go.
That's it.
What it says.
So to all you guys that are still struggling out there, the best advice that I can give you, and Jordan will say the same, Stephen will say the same, is just focus on getting sufficient levels of free testosterone. Okay. If you're way under, if you're way under 20, you gotta bring up your dose if you're symptomatic. If you're between 20 and 30, you're still symptomatic, you can probably go up. There's guys in our group that are 40, 50, 60, whatever it is. But if you're getting your dose up there and you're finding a way to keep those levels consistent throughout the week, and months have passed and you still have issues, okay, well, testosterone isn't your issue. But guess what? Neither is DHT, neither is estrogen, neither is forget that stuff. Just concentrate on T. And if you've got that done, put that aside. Say, okay, I've got healthy levels of testosterone now. What else can I address? You can address thyroid. You can address your nutrition. You can address your sleep. You can address your stress. You can address exercise. Maybe you got a food intolerance. Maybe you got a vitamin deficiency. Maybe all these other things. forget all of the other labs when it comes to hormones and just say, do I have sufficient levels of free testosterone? Yes or no. Don't rely on total, because I know plenty of guys that have total of 1200 and their free T is like 12 because their SHBG is skyrocketed. Okay, you're going to have to find a way. How do I get this free testosterone up? Get it up, get the levels consistent, give it time. Don't base your protocol after a week or 2 or 3. Give it 8 weeks and go from there. Don't add anything else. Go back to basics. The best thing I have ever done was just going back to basics and say, forget all these other supplements stuff. I'm just going to take tests. I'm going to get my levels up. I'm going to keep them stable. And then I'm just going to give it time. And literally with every passing month, I'm feeling better and I'm feeling better and I'm feeling better and I'm feeling better.
That is exactly, and this is not some conspiracy between me and Danny. That's exactly what I tell patients. When I see guys who are already on testosterone, they don't feel well, they're on these crappy protocols that we talked about. When they come to see me, I'm like, we're starting from scratch. We're dialing everything back, and we're going to get you dialed in on testosterone. And it's that simple. And we're going to ride it out. We're going to trust the process. And believe it or not, 2 months later, they're like messaging me on Facebook, like, I feel great. You know, I mean, every now and then I'll get somebody who goes, you know, my libido is still not quite what I think it should be. And we'll look at labs. Their free T is, 22. And I'll say, okay, we can try raising that and see. But it may not be your issue because, again, libido is a whole different topic. It's not just about testosterone or estrogen, in fact. A lot of estrogen.
Or thyroid
thyroid, life stress, whatever, dopamine. A lot of these guys are on other medicines. So, you mentioned getting your life in order, nutrition, sleep. Every guy I talk to, and even if you're an obese, 70-year-old guy, I'm like, you got to start doing something. You got to lose weight. You have to. Metabolic syndrome is one of the biggest deals in the world, I think, especially United States, as far as health hazards. So you got to work out, you got to eat right, you got to do all that stuff. And a lot of these guys,
there's so many guys that talk about, sorry to just say what you're saying. They say, I thought my TRT was good 2 years ago, but I had more body fat. I've lost a ton of body fat now. 2 years later, my dose is the same. I feel a million times better. It's as if the TRT, the testosterone is working better in my body now that I'm leaner than back when I had, 25, 30 pounds to lose.
It probably is working better, honestly. And their insulin sensitivity is better and they feel better. Yeah, it's a huge deal. And I think there is something to be said for these guys that do need higher doses to feel better. There's something to be said for the endocrine disrupting chemicals and the estrogen-like chemicals that are hitting receptors and causing these imbalances. They're not only estrogen receptors, but probably inhibiting androgen receptors as well. And so they do need higher doses. And that's something doctors, a lot of them don't believe in yet. Okay. I don't know for sure, but I think it's a thing. I believe people, and I've seen it. I've seen guys that, their total is, 1,200 and their free is 20. And most doctors look at that and say, you're too high. And they're like, I don't feel any different yet. And then you get them to whatever, a free T of 35. And they're like, I feel great. Like, I mean, that's not a huge difference. I mean, you're not going to turn somebody into a bodybuilder with that dose. So a lot of people think you're just abusing. It doesn't work that way. But if you can get them feeling better on that dose, they're better. That's it. End of story. So
and taking an AI is going to have no effect on all of these estrogens in the food or the water.
What it will do is it will raise the free testosterone, which may be what you needed in the first place. So it's masking. It's basically you're simulating what you needed in the first place. But then they have the other side effects. Yeah. So,
exactly.
We lose Stephen?
So let's see. Apparently he's, I don't know. He's gone. Oh, well. Hoping to put him to sleep. So guys, everyone watching you, if you liked this video and maybe it was an eye-opener for you and you're like, wow, I never looked at it that way, put a like, put a comment that explained to you what it was in the video that convinced you that maybe taking an AI is not a good idea. If you're not taking an AI and you feel good and you've been telling people not to, post comments about that also as well. And for those of you, like I said, that think that we're just making this up to convince you to make us join our magical anti-AI cult or whatever reason, write in a comment exactly what it is that you feel that we're doing to potentially try to mislead you. Because I can assure you, I make nothing of this at all. This is my free time. Jordan is a urologist. We're not even talking about his clinic. None of us are. This is just us spending some free time trying to get you guys to have the best info possible. That's all we're really trying to do. Jordan, it was great having you on as always. I can't wait to do that study
We'll get there.
overview.
Yeah.
Oh, Steven's back.
Yeah, I'm back.
Hey, there he is.
Steven's back.
I think he went and did some bicep curls real quick.
Yeah, I just did some curls.
I like it.
Okay, guys, thank you very much, and have yourselves a great weekend.
Thank you.
Bye-bye, guys. Thank you, Jordan.